Good afternoon and welcome to the breakout session entitled Insight on Improving Quality in Healthcare Through Wellness Interventions. I'm Michelle Strider. I'm the Chief Quality Officer for UVA Community Health at UVA Health, and I've had the privilege of serving as a member of the Planning Committee for this year's Safety Summit. It is now my pleasure to introduce our speaker for this session. Dr. Lisa Ellis is a full-time faculty member at VCU Health, where she is leading wellness efforts as the Executive Director of Provider and Trainee Wellness. She has led the VCU Health Wellness Task Force since 2017 and spearheaded countless wellness initiatives for the workforce since that time. She has given numerous presentations and workshops locally and nationally on wellness and burnout topics, and in 2020 won a national award for the wellness retreats she developed and provided for faculty at VCU Health. Dr. Ellis is a trained wellness champion by the American College of Physicians, is a certified facilitator trainer for Crucial Conversations, and completed coaching training in 2021. Most notably, Dr. Ellis is the co-investigator on an organizational wellness project awarded $1.5 million from HRSA's Health and Public Safety Workforce Resiliency Training Program. That work targets leadership training programs and performance improvement, which directly affects professional satisfaction, psychological safety, and retention of faculty for organizations. Her focus is to provide creative solutions which decrease bureaucratic and administrative burdens that lead to burnout of the healthcare workforce. She hopes to continue the development of sustainable wellness programs to help curb the rising levels of burnout in our workforce. We may have time for a question or two at the end of this presentation, so please feel free to put your questions in the Q&A box. And with that, please join me in welcoming Dr. Ellis.
Well, thank you so much, Michelle, for that wonderful introduction. I'm going to share my slides so that we can move ahead with this presentation. And again, I think Michelle will be helping us to take care of those questions afterwards. And I'll make sure I give my email address too, so that we can make connections if you need to, and we don't have time today. So we're talking about improving quality and wellness initiatives and how they might integrate together. And I'm so happy to be here with this group. It's been a very exciting day, great presentations, and just really, really so worth every bit of effort that's gone into this. I have no conflicts of interest to disclose, unfortunately. And we'll go right into this, looking at our objectives. We're really going to look and make sure that people understand what we're talking about when we're mentioning individual versus organizational wellness initiatives. We're also going to describe and make sure that people can define the quality implications and the safety risks that come about when we have a burned out workforce, and also recognize some strategies for solutions. I think getting to solutions is a wonderful goal for all of us. So first off, just looking at a very simple definition for wellness: the active pursuit of activities, choices, lifestyles that lead to a holistic health. Most of the time when we look at wellness, we can see an individual impact, a department, clinic, unit, or maybe a small building or location impact, an organizational whole impact, and maybe even national impact. Today for this presentation, we're going to be mostly talking about organizational impact. And the little bubbles over here on this other side of the slide tell us that we have many different aspects of wellness that we want to make sure that we are keeping in mind as we go through and look at our wellness strategies. And while emotional strategies are extremely important for us, we are going to focus on some of those other ones that bring in other people in our healthcare system. So we also need to look at how we're defining burnout, because it means many different things to everyone. But the WHO redefined burnout in 2019. And as they said here, syndrome that's tied to chronic workplace stress that's maybe not been managed as well, feelings of energy depletion or exhaustion, and increased mental distance from one's job. Important for us to think about that. Feelings of negativism or cynicism that are related to one's job, and a reduced professional efficiency. So when we look at burnout, and then we would say, well, what might that look like in our burned out workforce? In our burned out workforce, we might see a number of different constellation of symptoms, but many times we might see people who are perhaps angry or irritable or impatient, Maybe we might see people who do not show up as much. They've got increased absenteeism, trying to find ways that they can get away from it because they're too burnt out. A decreased productivity and a decreased maybe quality in their work. Well, if I was a quality officer like Michelle is at UVA, if I was looking at this and I thought, wow, increased mental distance from one's job, to me, that might speak to the problems that come about when somebody's maybe distracted or not paying as much attention to their work, or becoming careless at looking at all of the protocols and the ways that we need to do things to keep people safe. And reduced professional efficiency absolutely speaks right to some of our quality and performance improvement measures. And looking at absenteeism, productivity, and quality of work, if any healthcare system knew that you had something that was going to erode your quality of care, your productivity, your workforce access to patients' care, I think any organization would say, we don't want to just look at this for how we're going to take care of one person. How are we going to do this from an entire organizational impact? And that's really what we want to look at today. So we're looking at what we're talking about is the organizational approach to wellness. All of those individual measures and things are extremely important, but we need us to be able to lift up higher and look at this from the full organizational approach. So supporting healthcare workers is really about reducing all the bureaucratic barriers that we have that make it so it might not be as easy to do our jobs. Looking at things like environments, our processes, our policies, our trends in leadership, even the culture of an institution, maybe how we divvy out resources and supplies. And if we think back for a minute, we try to figure out, have we ever done this as an organizational process before? Have we ever all been in a situation where we've had a lot of wellness issues that maybe affected how people felt, and we had risks that we needed to make sure we were going to overcome, and the organization had to work as a whole to figure out, what do we do with those? Well, I know that you've probably come to the same conclusion that I did. And with that, I'm looking at COVID. So absolutely, when we look at COVID and we need to make sure that we're learning whatever we possibly can from COVID, we had many things that were happening that were really affecting the wellness with our workforce. We had things with anxiety and fear for their health and their families. And we had lots of risk to our quality issues, but our organizations really stepped up to the plate to do whatever they needed to do to help us through that. So let's take a look at that. So over on the left, thinking hard, it's not a hard thing to go back and try to remember what was it like those first few weeks when we first learned about coronavirus. What we experienced was, through our hospital organizations, anxiety, confusion, chaos. I'm sure you could list many of them, but when we looked at our workforce, that is what we saw throughout the public. We saw that. And we also knew very well that when you have anxiety and confusion and chaos, your risk of errors may possibly just skyrocket. Your lack of teamwork is going to potentially put some errors in place that you wouldn't expect to have happen. And all of the healthcare systems, not just in Richmond or Virginia, but across the nation and probably across the world, realized we need to figure out how we do things differently right now. As an organization, they're responding to the anxiety, the confusion, and the chaos, which are absolute wellness things that we measure, but because of the potential outcomes that were quality outcomes. So we can already see how these integrate so closely together. They enhanced, these are just examples of what we did. Many things happened, but communication everywhere was enhanced. Everyone knew we had to talk about this. We had to be in forums and in town halls and in daily meetings, sometimes 3-4 times a day, and huddles and more communication with your teams, because people were wanting to get all the information they could to make it be not as confusing. We also didn't know anything about coronavirus, so we had confusion and frustration there. When we don't know what we're doing, people get confused, and that's a big part of our wellness. not having the right knowledge to do the work, people being deployed to different places. The potential outcome with that was quality outcomes, delays in treatments for our patients, maybe the wrong treatments. Do we wear masks? Do we not wear masks? Those were the quality outcomes that we were looking at, trying to hold them in place and not have them let go. And how healthcare teams responded was you teach and train. Very quickly, people found every protocol they could. We were glued to webinars like this. We used FHHA, VHHA, and the Virginia Department of Health, every aspect that we could to get external and internal training done so that we could develop the protocols and put them in place so that we could help our people not feel a lack of knowledge or confusion and make sure that we didn't have these quality outcomes. When we shut down clinics and we shut down procedures and surgeries, of course, the people with the potential outcomes were financial upheaval, and were we going to get our patients taken care of? So again, there was also fear for, am I going to get furloughed? Am I going to be able to get paid if my productivity is down? We decided, not as a state, but as an entire, a whole country, deliver treatment differently, relax the regulatory aspects that we possibly can, telehealth like we had not ever done before, even documenting in slightly different ways. So we knew that we can lift up as an organization, and these are really great examples of organizational ways that we take care of the wellness issues that are absolutely going to affect our quality problems. We know too that the individual measures are extremely important. So my message is not that these are not important. My message is that if we told people everything's going to be fine, just go home and eat well and make sure that you're exercising, that might not have gotten to the aspects of what we had as problems than it did when we as an organization had larger initiatives that we did to try to make sure that all of those anxieties and confusions were taken care of. These are still very important, but do we get as far as we need to with them? Again, we've looked at some studies that have showed us back in 2016, so this is before COVID even started, and we have been dealing with this problem way before COVID started, and we're going to deal with it as COVID relaxes as well. We looked at studies that showed mindfulness, counseling, coping strategies, all extremely important. So don't get me wrong, they are, but they made minimal changes and they were not sustainable throughout the organizations. But when we looked at things that organizations did, like changes in scheduling, teamwork training, enhancing job control, inclusivity, those were the things that we saw that had significantly larger effects on changing the overall burnout everywhere. So we look at that and say, what about other quality things that can happen? We know already turnover, we're living in turnover problems right now. We know that. And we know that burnout is equal to the intention to leave. People that are burned out have an intention to potentially leave. Intention to leave highly correlates with actual departures. So we need to try to figure out, what do we need to do so we don't get people burnt out, so they don't have an intention to leave? And we're going to find out that some of these things do not cost us very much to do, but it certainly is costly to have people leave. 2 to 3 times salaries for the work that could be done that's not done. And for physicians, somewhere upward above $1 million when people are leaving. Just all the lost patients, the lack of continuity, and the devastation to teams. It's just so important for us. But we also look at productivity and access. We sometimes do a 10-question mini-Z standardized burnout at our organization. And we know from research that's been done by Tate Shanafelt that for every 1 point, just 1 point higher on a burnout scale, there's almost upwards to a 50% likelihood that that worker is going to reduce their professional effort. We can't afford to have anybody reduce their professional effort, but they're reducing their professional effort sometimes because they have fear as well. When people are at that point of, do I stay or do I go? And what is it that's going to tip people over the edge? The most powerful driver is the ability to provide the best possible safe patient care. And when that's challenged, people will pull away will try to see less patients, will do anything that they can to make sure that they are keeping their patients as safe as possible for however long it might take to do that. So we know that this also, when we have people burnt out, is going to affect the productivity and the access to care. We also know we're at the quality, safety, even patient satisfaction avenues with this. This is a picture of someone who was around quite a while ago, but C. Everett Koop was our Surgeon General a while ago, and he was one of the first guys that really looked at what are we doing about non-compliance? And he said, of course, drugs don't work when people don't take them. So this has been looked at very carefully by many different studies. And he also found that we had $100 to $300 billion annually in avoidable healthcare costs from people who didn't follow treatments or take their medications. So when you look at low burnout teams, I'm talking about the teams, people are calling and connecting with patients, the physicians, the nurse practitioners, the nurses. When you have a low burnout team, the rate of compliance with cancer screening was almost up to 30% higher. Really interesting to me. Also, higher satisfaction from patients who think that their listening skills of that team was so much better and their accuracy for diagnostics was so much better because they were listening better. And also patients reported that they felt like they could disclose more during their visits with their healthcare team and that they then were more compliant with their therapies. We looked at higher burnout teams, more complications, more hospital admissions, and for some reason, more diabetes problems. 7,000 surgeons were looked at in this other study that I list there who reported high burnout. And of those 7,000, 45% higher odds of a major medical mistake. And this was looked at for a 3-year surveying study. The last one is patients from teams that are burnt out are actually found to be less compliant with their medications, and they have worse outcomes on their hemoglobin A1Cs, which is their diabetes markers. Maybe patients aren't understanding, but maybe teams aren't able to take the time and really devote themselves to the ways they would be working with those patients to help them understand better. We don't know for sure, but we do know that these facts are real. So why should organizations care? Well, to me, I think, why would organizations not care? Obviously, right now, we are living and breathing problems with burnout, and we are finding that all of the things that we know matter to all of our organizations, our performances, our readmissions, length of stays, safety errors, patient satisfaction, recruitment, access to care, and how we care about each other is just a moral compass. Why would hospitals never not care? And we're also looking at all of the shortages that we have, and we're asking people, why are you leaving? What's happening with that? We know as well that the number one reason that people feel that they leave jobs is maybe they don't feel valued and respected. When we're looking at those things that are at risk, and we're seeing the number one reason that people leave, and it costs us $0 to figure out some resources that help people feel valued and respected. And I'm going to talk a little bit about those, or what we might want to do as a beginning step in a healthcare system to try to figure out, what do we do to take care of this? We need solutions. We're all agreeing that we know this is real. We're living it right now. But what can we do to actually do something about it in our organizations? We suggest you actually build a program. Building a program just like you would build a finance program. You need structure, you need framework. We want people that are trained individuals with protected time to do this. You can't do this with people that are doing it in their spare time. You've already seen all of the immense areas that this has an impact on. We're living that right now. And we know it does not cost a lot of money to change some of the things that are basic principles for being able to have a good wellness program. As we learned about in the panel this morning, we looked at a 5-prong approach with this, starting with a visible commitment. You don't want to start with an initiative. You don't want to start with potlucks. You don't want to start with something until you've got really good structure and framework. So as VHHA said this morning in the panel and the task force work that we've been doing, you start with a visible commitment, and that can be whatever you decide it's going to be. a statement from the organization, statement from a leader, pledges from leaders, things that are on websites or in the elevators or in an email that goes out. But somehow you've got people in charge and you have a steering committee. And that steering committee, we already know that IT affects wellness and burnout. So do HR and the benefits we have or don't have. And as well, when we look at all of our risk people, all of our folks that are doing great jobs, they should be the ones that are really understanding this, living and breathing it, because these things affect their work as well. So having these people on your steering committee is hugely important. Once you've got your steering committee, setting up your surveys, and don't be afraid of them. Ask however you can, but you need to have a regular cadence. Simplify your surveys for whatever it is you're sending out to people. Make sure you have the quickest turnaround. Share that data as fast as you can with the teams. And your priorities and your initiatives need to come directly off of that survey and analysis. If you do what you think you should do, you're going to lose the opportunity to build right off those KPIs. The data that comes right from those surveys with the people that have had it, those are the meaningful quality projects that you start to build. And if you don't have a really good communication process or team, you need to make sure that you have that. You have to be able to get resources out to people, get understandings for how they can get their ideas to you. And you need a repository and you need to have good communication that comes out. Once you start with your projects, you're all in the same organization. The chances that one project might be good for one clinic and it also might be good for another is pretty high. So that's when you start to be able to collaborate and have shared governance across the organization. And you have so much inclusivity because everybody wants a piece of what we're going to do to help keep people less burnt out. So we're going to take a few examples of organizational levels of solutions that we could have to help you with what are some of the initiatives that you might do that would integrate what we might think as quality and wellness, and maybe give a start to things that you may be already doing, but you just need to put a little bit more meat around them to show people that this is actually a good thing that we're doing for wellness. So we start off with looking at reviewing exit surveys and retention trends. We know right now, I don't think there's a hospital or an organization anywhere that is not experiencing overwhelming staff and faculty shortages. We know too, we've got some quality issues that are really suffering with that. Risk of errors, risk on patient experience. It's tough on finances. It's tough on access. It's tough on productivity. All those things could suffer. So I'm just grabbing a scenario and wherever this hospital might be, but at this particular place that I know of, 43 nurse practitioners had resigned in less than a year. They didn't do exit trends at first, but later came back around and did some exit surveys. The top reasons they were so sad to find out were these people needed more flexible hours. They needed to be able to work part-time. They didn't know if their kids were going to be in school or out of school. They didn't know how they were going to take care of their parents. They were also worried about the safety of their patients, and they didn't feel included in decisions. Those last two go together. But when you're able to look at those trends and you're able to see what they are, you might have an example of the nurse practitioner in the picture who looks like he's having a lovely time with his daughter, having tea in the afternoon, which is what you want to be able to do. So what we say is take the exit surveys, but don't only do exit surveys, also do intention to stay. Talk to managers about people that they say are not going anywhere. And then you might want to have somebody other than the supervisors do that so that people can really feel like they're speaking candidly. But what worked for people when they are leaving? What could we have done differently? And why now? You stayed all through this. Why now? What tipped you over the edge? For the people that are staying, what works for you? Why do you think your coworkers left? What are we doing well? The information you could get from that is so valuable. It's golden. And knowing those top 5 areas of concern and knowing why people want to stay that you can just publicize as well, getting ahead of the trend curve, use your teams to talk about those problems because getting their perspectives is really sometimes all we need. So solution number 2, evaluate that burnout and share that data as fast as you can. Sometimes what we do is we pick things to do and we don't really even know if the things that we've determined are important for everyone that we put initiatives behind, they might not even be the pathways that are the needs of the team. We need to hear from them also that don't have a great place to speak up. Don't be afraid to do something that asks the tough questions. We will end up having finances and resources that are not matching up with really something that's going to make a difference. And we may have some actual $0 initiatives that we can use. So at our organization, a couple of things that we did during this COVID times, we did COVID surveys that were just pulse surveys. And I'm not saying they would work for everybody, but they sure were simple. And they were 2 questions. And they also had 2 questions that people could opt into doing write-in answers. We asked if they're male or female, and we asked where they worked. Not the exact where they work, but are they a nurse? They work in IT, they work in finance, just so we could kind of pull a few little bits of data together. Our 2 questions were, how do you rate work right now? How satisfied are you with work? How satisfied are you with the support for work right now? And then our fill-in question was, what's working and what could we do better? So our responses with this, we closed it in less than 2 weeks, but in the first 48 hours, we had almost all of these respondents, 4,367 people giving us how they felt about it. That's golden for us to be able to get that kind of data and look at it and be able to make quick decisions about what the people are saying. You see trends pretty quickly on these. So we could do a quick turnaround, and people brought it up in the town halls, or they wanted to see the data at other meetings where we had a lot of people. And I think this is really interesting. Less than 50% of people were satisfied with work. Yes, I get that. This was COVID. Nobody really loved their work at that time. It was scary. It was anxiety provoking. You didn't know what was happening from one day to the next. I would say that was pretty darn honest, that people were less than 50% of the time satisfied with their work. But 73% of the time saying we were satisfied with the support that we had for work. And some people brought that into the things that they wrote, saying, we know this is not your fault and you're doing everything you can for us. So we take the top concerns. Number 1, across the board, confusing communication. There's a lot of confusing communication everywhere, but could we do it better? So this is an organizational response to the wellness questions of, do I feel supported? Can we clean up our communication? Can we make it crisp? Can we make sure that we're cascading it down? Can we increase it? All of the things that we do to make sure that we aren't getting, we're getting to the people for what they wrote as their issues and concerns. And positively, they loved the remote working, so we kept working with that as much as we could and offered more benefit for it. You can also use some standardized tests, and we will have those on the VHHA site. But you may already have some data. You may already have culture surveys, Press Ganey, or engagement surveys. You can go through those surveys and pull out the questions that are your wellness questions, and you've got a batch of data that you can already start to work with. It's not hard. And you can also then take the things that you learn from that and figure out what are the few things that you can do that are going to make a difference, because that's what the people told us was the problem. Really important to do. One other project that we had, this is not ours at our organization though, but how important it is to have inclusivity and transparency. And I'm just bringing up things that don't really cost us too much, but they made a huge impact. So the right people not being included in the basic decisions, what do we get with that? People not feeling valued, not feeling respected. We already said those were the number 2 reasons that people don't stay in jobs. People become cynical, burn out, projects fail, lack of engagement. That is just the definition for burned out. And we could have included people. So at this scenario, hemorrhaging money for toner, and then somebody says, we've got to get rid of all the printers. The printers got to go. We have way too many printers. We all agree with that. Everybody agrees with that. We don't want to hemorrhage money when we don't need to, but they didn't talk to people about it. So people all come in after a weekend. Everybody's printers are gone. People are angry. People want to know, what am I supposed to do now? What's the new workflow? Why weren't we valued or respected enough to have somebody come and ask us about this? Where's my printer? When you take a root cause analysis that we use in quality every day, and you use it on a problem like this, you're going to show people what went wrong, who should have been around the table, how could we solve this problem together, and at the same time, you're respecting your workforce, communicating issues, asking for input on solving them, and you might even get a better result. So I say use your quality tools of root cause analysis, because I'll tell you, this was not a printer problem. This was a communication problem. And as soon as you try to solve a printer problem, you're going to go around the corner and find the same communication problem comes right back at you again. So see this for what it is, that it's a communication issue, and you can solve this with doing a root cause analysis. And I loved one of our keynotes today saying, remembering the mantra, nothing about us without us, really important. It doesn't have to be everybody, and it doesn't have to be that your message changes. Just like we tell children, you want to put your coat on, or do you want me to help you put your coat on? The result is the same, but you're giving people an opportunity to be a part of that, or tell them why it's happening. The last one is autonomy. Autonomy is a tough one because we definitely do understand we need to work very much the same in order to get to some better efficiencies, like we talked about this morning in antibiotics. But the loss of control of processes when people haven't been brought into those decisions, coupled with the inability to explain those needs, will sometimes make people feel more anxious that their patients are not being well taken care of. This is where you see physicians opt out all the time. And that's what we hear. Those physicians, they opt out of everything. I will tell you, I don't know of a physician situation that they have opted out of something that is working beautifully. If it's not working beautifully and there's a chance that their patients aren't going to get in or their patients aren't going to be well taken care of, you can bet they are going to try to opt out. Sometimes looking at the opt out and why and what it is people are doing when they're opting out might even give you better solutions. But increasing those issues with trust for safety and quality is what we're really talking about with that. This one situation for this scenario was people decided we are wasting way too much time in this clinic with people who are coming in for half clinics. They're only doing 3 to 5, or they're doing 8 to 10. And they came back and said, we can't figure out our resources if all of the nurses are not sure when people are coming or going, and it's much too much confusion. And we are just going to have to make a no opt-out solution that all physicians and nurse practitioners will see patients only from 8 to 12, 1 to 5. No excuses, no changes. The first thing that happens is this cardiology group says, but I have to round on my patients before I get there. How am I going to be able to get there? And if I go much earlier, I miss the families. Somebody else is saying, I teach a class at this time. I'm at an academic center. I can't get there until this time. They're saying, I'm sorry, you got to have a session that's 4 hours or you can't be there. So what one group did was say, what's the problem you're really trying to solve? And the problem they were really trying to solve is they needed those rooms filled from 8 to 5. Well, if you give that problem to a group of people and say, you have 30 days to try whatever it is you want to do to make that solutions that come. So with that group, they gave these group of cardiologists and said, you've got 30 days to figure this out. They figured it out. They said, this person will be there from 8 to 10. This person will be there from 10 to 1. This person will be there from 1 to 5. One person got to spend more time with families while they were actually on rounds. The nurse practitioner that was there working at a different time got her able to get some of her prior awesome notes done and work as a team. And the Dr. C was in class but able to go and see his patients. Problems were solved. The rooms were filled from 8 to 5, and the docs worked extra hard to make sure that their way was going to actually work. It never, ever hurts us to at least see what somebody else's ideas might be and make sure we're all clear on the problems that we're solving. Lastly, don't forget your leaders too. The leaders are burned out. We have to make sure they are the ones that have a climate of a workplace that can be tracked back to them. So this article just came out and it says, burnout in medicine is a public health crisis, and was so even before the onset of COVID-19. We know that. It has been increasingly linked to compromised patient care, diminished quality of safety, physician and nurse turnover, financial effects on healthcare organizations, and the personal toll. So this is a call for action for leaders in healthcare systems to really develop the structure and the framework and give visible commitments to the well-being of workforces. So I will stop at this point. I have my email address that is available on there, and I think Michelle might even be able to put it up through the chat if people want to have questions that we don't get to today. But I know that we wanted to give a few minutes for questions. I really thank you for coming today and being a part of this this whole day and this whole summit. I think it's just incredible that it's being done, and I'm so delighted that I was here. So thank you to VHHA for inviting me as well. And Michelle, I think I turn it over to you to see if you have some questions. I'll stop sharing.
You're good. Absolutely. Thank you, Dr. Ellis, for such a wonderful presentation. We only have about 2 minutes and we have 2 questions. We'll see if we can get to those. I did put Dr. Ellis's email address in the chat, so you can find that there if you have something we do not get to. One question is, do you have any recommendations on how to incorporate bedside care team members in projects without overtaxing them during high census and or staffing challenges? Something we're all familiar with these days.
Absolutely. So I think the most important thing is remembering it's the same as if you had a really strong financial initiative that was starting and you needed people to be able to be a part of that. We would have the financial people do that. You don't have people in their spare time that kind of like dealing in finances to be a part of that. Their job, remembering what people's jobs are, their job is to absolutely be at the bedside and do that work. And that's why this is organizational wellness. You have your organization determine how that gets to them. It can't be their problem to figure out how they get to you. That's why it has to be an organizational, all-out organizational approach to doing this with people that is their full-time job, not their spare time job.
Great, thank you. And then last question, can you let us know about the importance of continuing this work even in a post-acute COVID state as we move into that?
Yep. So most of I started training in this in 2014, 2015, and all of the great research studies and wonderful work that's been going on in this, a lot of it is all done way before COVID. You know, Brian Sexton was here however many years ago talking to us. All of these things is research that started way before COVID. It is not going away. We have physicians that were at the 50th to 60th percentile of being burnt out, but no one understood what it was. Now we have this golden opportunity because we really are seeing the implications. The implications are not going to go away. They just were not looked at the same. People were doing things like, let's just make sure that we are bringing the ice cream truck. Really important, but it's more than that. Right now, like what we're doing with this HRSA grant is teaching the leaders the impact of psychological safety in the organization for actually being able to have people speak up and being able to have people understand how important psychological safety is. There are impacts with teams that feel psychologically safe, having much better quality and financial outcomes. The true cost of burnout is real, and it has been for many years. It's just great that we've had this opportunity to see what it's done.
Great. Thank you for bringing that to light, Dr. Ellis. Thank you again for our great presentation. We will now end this session and provide our attendees a few minutes to transition to their next breakout session. Thank you.
Thank you.